So my name is Gail Roboz. I'm sitting in New York at the moment, not in California, which is actually where I wanted to be. My sister, in fact, lives in San Mateo, and I was really hoping to be there, but this is the next best thing, so thank you for making it happen. Thank you very much for the invitation. I'm a professor of medicine, and I run the leukemia programs at Weill Cornell Medicine and the New York Presbyterian Hospital, and it's really such a pleasure to be with this group. I'm going to shift gears though, because you guys heard a bench talk by Dr. Jameson, which is incredibly exciting work designed. You know, the buzzwords that you want to hear are prevention, and also leukemia is of course a buzzword for every patient with MPN who's frightened of progression to leukemia, and we want to hear that we're going to be able to either prevent the disease altogether or prevent it from getting worse. But in the meantime, down here on planet Earth, before we are able to go into space, we've got a bunch of diseases with a lot of symptoms, and symptom management in myeloproliferative diseases is very difficult because there are symptoms that are quite broad and far-reaching associated with the disease. There are symptoms that are associated with worrying about the disease, and there are plenty of symptoms and side effects associated with the management of the disease and a variety of therapies. And by the way, just for the group out there, while we certainly all worry about progression to leukemia, by far the majority of patients don't actually progress to leukemia. They don't have a leukemic transformation. And unfortunately, there are plenty of symptoms to manage long before that event of leukemia ever happens. And again, for the majority, it doesn't. So what do we do about this? These are my disclosures, which I think are available in whatever pamphlet you had. So in thinking about how to construct this talk for you, I decided I'm just going to Google it like everybody else does and say, what are the symptoms of MPN? My doctor just told me I have that. I don't even really know what it stands for, but how bad is it? And so in 0.54 seconds, you get 1.2 million results, which is an extraordinary thing. And here are the search results. And the search results show headache, blurred vision, fatigue, weakness, dizziness, itchiness, otherwise known as pruritus, night sweats, and raised blood pressure. So is it fair for me to say that I guess all of us have an MPN? Because I don't think I've ever spoken to anybody who doesn't have at least one of these symptoms, and on a Friday you're going to have most of them. So now what? This is the most non-specific set of symptoms that one could ever see. And again, it's difficult to imagine that anybody in the room or out there watching hasn't had one of these. So what does this mean, and for how long, and how severe do they have to be? And do I have this? I came to this to thinking that I was watching a show that was relevant to my cousin, but maybe I have an MPN. So I think we have to spend a lot of careful thought to how to organize these very, very broad symptoms that could be associated with the disease. So I said, okay, well, forget Google. Dr. Google's a bad doctor. I've got to be better than Dr. Google. So let me go on to some trusted and true websites. So I have on the left side, or at least it's my left, from the MPN Research Foundation, and from the right side from LLS. These are trusted, valuable organizations that have a lot of excellent information, by the way, that you guys should definitely look at. But I said, all right, let me just put in myelofibrosis and see what they say. Well, there are an awful lot of bullet points, and they're not exactly the same on both sides, but let's talk about this for a minute. Okay, tiredness, weakness, or shortness of breath with mild exertion. Okay, and that's on both sides of the chart here. Tiredness on the left, fatigue on the right. I don't know anybody who doesn't have tiredness or fatigue, and COVID didn't help with any of that. But the problem is that fatigue actually characterizes pretty much all of bone marrow disease. And I say to patients about 50 times a day that I don't have anybody in my office who doesn't have fatigue. And what does fatigue actually mean? How much fatigue? How symptomatic are you? Does it go along with anemia or not? I have patients who come in with a pretty normal hemoglobin, but they have fatigue and they have an MPN, and the doctor says to them, well, you can't have fatigue because you're not anemic. Well, that's not true either. So we are on bullet point 1, and we could spend a long time talking about this. Going down to other side effects, other symptoms that one has to be careful about, and I'm going to focus on the column on the left, but there's a lot of overlap. So fullness, discomfort, or pain in the left upper quadrant, this is associated often with splenomegaly. So what about if you have pain or fullness there, but you don't have an enlarged spleen? I have lots of patients who have left upper quadrant discomfort who really don't have much in terms of a big spleen. So what's that all about? Is somebody feeling something that isn't there? Again, I'm talking at a conference here which is designed for specifically looking at women. I think women, most people would agree, are blown off more easily than men when they complain about things. But in particular, if you're complaining about something that I can't see on a scan or feel, what do we do with that? You have fullness or you have discomfort on the left upper quadrant and you don't have a big spleen, the doctor is pretty likely to say, well, that's not it. Fever, night sweats, weight loss, bone pain, easy bruising, susceptibility to infection, portal hypertension, or what happens when there's plugging up of the blood vessels that is mucking up the kind of plumbing system between the liver and the spleen. This can be due to blood clots, this can be due to organ enlargement, this can result in organ enlargement. This can also result in compromised liver function. And then we have the bottom one, or abnormal growth of blood-forming cells outside of the bone marrow, which is called extramedullary hematopoiesis. So looking at myelofibrosis, a disease in which you have abnormal scar tissue forming in the marrow is getting scarred down, it is not producing blood correctly. The spleen thinks it can solve this problem. Whoever invented this system might not have been paying good enough attention at the time, because the spleen thinks it can make blood, so it tries to compensate for the bone marrow, it gets bigger, and lots of these things can be symptoms that myelofibrosis patients really suffer from. Now, what about the fact that we're not only talking about myelofibrosis? So there is a Venn diagram that all of you watching probably have some knowledge of, that it used to be that all of these different columns on different slides were very, very different diseases. Myelofibrosis, essential thrombocythemia, polycythemia vera, which I'm going to show next. When I put them like this on different slides with different boxes, it feels like they are completely different. Like, okay, I have ET, I don't need to be listening to the myelofibrosis. But we know now that this isn't true, and these diseases are on a Venn diagram with you can remember the Venn diagrams from, I don't know, first grade or whenever we learned about that there's a lot of intersection and overlap between them. There is also a lot of crisscross between them, because sometimes patients are initially given a diagnosis of, let's say, ET, but then a year or two later, the doctor might say, well, actually, this is more consistent with PV. Patients get very upset by this. Well, did I get the wrong thing? Did I get the wrong diagnosis? So just understand, as we go through this presentation, which is talking about medications and talking about symptoms and talking about side effects for 3 different diseases, they're not so different. There are lots of things about myelofibrosis, ET, and PV that actually very much overlap. And furthermore, ET and polycythemia may ultimately turn into more myelofibrotic diseases or have secondary myelofibrosis. So everybody has to kind of pay attention to all of this, because it may be more relevant to you than you think, even if your letters of your disease are kind of in one of the other slides. ET, now look at these. I know this doesn't look the same at all. So if you put ET on the MPN Research Foundation, you get these bullet points on the left, but on the right-hand side, well, that looks a lot worse coming out of LLS. So what's happening there? Well, again, it's the expansion of potential side effects that they were, or symptoms that they were trying to be a little bit more succinct about on the left. The left, they're saying headaches, vision disturbances, dizziness. Again, dizziness. Everybody is dizzy at some point. If you're dizzy for a minute, dizzy for an hour, dizzy for 3 weeks, what does that mean? Coldness or blueness of the fingers and toes, consistent with a Raynaud's type of phenomenon. There's a very specific thing called erythromelalgia, which is burning, redness, and pain in the hands and feet. This can happen in ET, it can happen in PV. Patients will come in sometimes and tell me, I don't know what's going on. It feels like I took my hands and I put them on a hot stove and they're burnt. So burning, redness, hands and feet, and then of course bleeding, easy bruising, easy see bleeding, sometimes minor, a little bit of a nosebleed, just some bruising that's not that significant. You're not even sure if it's major, ranging all the way to gastrointestinal bleeding that is very significant. If you look a little bit more on the right, you're going to see some of the details here that are related to abnormal blood clots going to the wrong place. So for example, chest pain, shortness of breath. Could this be a heart attack caused by a blood clot? Could this be a pulmonary embolism caused by a blood clot? The symptoms tend to be major ones that bring you into the emergency room are more likely to get you to the right diagnosis, but it's things like headaches and dizziness that can be so easily attributed to a million other things, and everything these days is COVID. Everybody only wants to think about COVID. So if you go into the office with headache, dizziness, and low-grade fever, I promise you everybody's thinking COVID, not an MPN. So how do you help the doctors, and how do you help yourself sort out what is causing what, is what I'm trying to get at. Big things like blood clots leading to, pulmonary embolism, to myocardial infarctions, to major GI bleeds. These are things that you don't want to have, except they're more likely to actually get correctly diagnosed because you're ending up in an emergency situation or in a serious situation in which people are going to be looking for the cause of whatever that event is. I think it's important to see that something like ET, for many, many patients, for many, many years, they will not have anything in the serious category. They can have ET and have a little bit of nothing, but it is a disease that also can behave more significantly and cause these serious side effects as written. Moving into polycythemia, again, fatigue, number 1 on the right, pruritus, number 2 on the right. Here too, if you look at the left side, headaches, sweating, ringing in the ears. It's what I'm trying to get at is many, many different side effects, but it's when you put them all together. So you can't, for these types of diseases, you can't pull one thing out. You can't say, oh, I have fatigue, that's it. You can't say, oh, I have night sweats, because especially if you're a woman, somebody's gonna tell you you're menopausal. It's putting together a picture of what do I have that goes together. And if you look at some of these, if you start saying, headache, night sweats, tinnitus, ringing in the ears, I have itching at times when I don't have any reason to be itching. I can't eat as much as I usually do. I used to sit down with 3 cheeseburgers. Now I'm sitting down with a small amount and I feel full. Maybe I'm feeling something on my left side. Putting together what are the things that you are going to call side effects and symptoms related to your disease, because in a minute when I go over to treatment, you're going to need to figure out what am I really thinking is caused by my MPN versus what's caused by other stuff that happens to me. If I have an MPN plus something else happens, I get, I get COVID, or I get another infection, or I have something else going on. And then on top of that, what's going to be caused by my medications? So I think really reading through these lots of different lists, a lot of them is repetitive information, and putting together for yourself, what do I think is caused by my MPN, and what do I think is quote unquote other stuff, so that I know how to track it. And here I show the MPN symptom assessment form, which has actually become very important in clinical trials, because in clinical trials in particular, you're trying to figure out what does the drug actually do for the patient. It doesn't get rid of these drugs that we have for MPN, don't get rid of the disease completely. I wish they did, but they don't. But in the development of this MPN symptom assessment form, and this is the abbreviated version that's most commonly used, the investigators tried to put together, okay, what is the totality, what is the picture of things that is most likely to be MPN related, specific, have a very high impact for patients, and can we get rid of at least some of this? Can we make this better with medication? So here, fatigue, filling up quickly when you eat, what the docs will talk about as early satiety, abdominal discomfort, inactivity. Can you not get out of bed? Can you not actually have enough energy to do what you would normally be doing? Problems with concentration, again, compared to before. If you couldn't concentrate when you were 4, it's not likely that being 60 and having an MPN is going to make that better. So what is new? Night sweats. Not it's hot and I'm gonna throw off a blanket. Not my wife's annoying me because it's too hot in the room. Night sweats where you're wringing out the t-shirt, really drenched. Itching, pruritus, something that is really bothering you, affecting your life because you constantly feel like you're scratching. Bone pain, diffuse, not joint pain or arthritis, deep, nagging, aching bone pain, fevers of over 100, or unintentional weight loss over the last 6 months. So this is your core set. Don't go through list and list of symptoms and try to find like, yep, I have that one, I have that one. Many people in the room might have things that are unique to their presentation and those are important, but this is the core set, and the one, by the way, that is defining responses to medications that you may be offered when you go to your doctor visits. So it's worthwhile to know what were the things that got better in patients. Now, this isn't a therapy talk for doctors, but I want to give people in the room a chance to have a look at what we see, what we might see as a physician if we go in and say, okay, in this case, myelofibrosis, I have a lower risk myelofibrosis patient. Your doctors can go over with you how you might be categorized for risk stratification based on things like blood counts and bone marrow findings, and sometimes mutational results or next generation sequencing results. But what I want to show you here is that number one, assess the symptom burden, and using that symptom assessment form, if you haven't done it before, asymptomatic versus symptomatic. So this is why it's important to have a core idea of what your own symptoms are, so that also you can put it together as a picture for physicians, so that they're not saying, oh, well, never mind your headache, never mind your fatigue. It's all part of a package. So here, if you're an asymptomatic patient with myelofibrosis, you might actually just be watched for a while. You might also, if you're symptomatic, go on to medications, for example, ruxolitinib or PEG interferon or hydroxyurea, and I'm going to talk a little bit about these. But what I want to call your attention to is how many times you're going to see signs and symptoms in algorithms related to MPN treatment. And if you don't know what your signs and symptoms are of the disease, you're going to really have a struggle figuring out, well, what is the disease's fault and what is the drug's fault? And I'll show you a little about the drug-related side effects in a minute. If you look at the higher risk disease, this is for higher risk myelofibrosis, again with risk stratification being explained to you by your doctor, that based on your bone marrow biopsy, your blood counts, and your, for example, cytogenetics, blast count, molecular profile, this is where we think you are. Well, now you start looking into details. You have a higher risk patient. Platelets are low, platelets are high. Are you going to use a transplant? Are you not going to use a transplant? But again, the same medications keep coming up because we don't have 55 different medications in this disease. Might you use ruxolitinib? Might you use fedratinib, which we heard about a minute ago from Dr. Jameson a little bit. But again, how are you going to know if they're working? Monitor response and signs and symptoms of disease. This is a disease, MPNs and myelofibrosis in particular is a disease where signs and symptoms of the disease are very much part of the monitoring and the response to therapy. Not all hematological malignancies, in fact, I would argue that very few of them are like this. In acute leukemia, in CML, while we always want to monitor patients for side effects of therapy, we're not following the disease and making decisions based on symptoms and side effects the way that we are necessarily here in the MPNs. So what are some of these side effects that I'm talking about? This is straight out of the package insert, so I didn't want to put anything here that is different from what you would find. So if you look up ruxolitinib and you look up package insert, which lots of patients do, this is what it says. The most common hematologic adverse reactions are thrombocythemia and anemia, low platelets, low red count. Fine, you can go over that and look at your CBCs, that's objective. But non-hematologic adverse reactions, bruising, dizziness, headache, and diarrhea. Well, that's all on the lists that I just showed you of what you started out with. So what are you going to do? Start circling bruises and see whether you have more than when you started with the disease? Well, actually, you might. Bruising, dizziness, and headache. Do I know what I had before, and are they getting worse? Now, the fedratinib, the most common adverse reactions: diarrhea, nausea, anemia, and vomiting. There is a black box warning for encephalopathy, including Wernicke's, which my colleague Dr. Jameson alluded to in the previous presentation. It's kind of a different issue. It's pretty much addressed by noting thiamine intake, and doctors will talk to you in fedratinib about this. Anything that's a black box warning always scares patients. Most of the time we can address this very well by just making sure that thiamine levels and nutrition are okay. But what I want to focus on is, again, diarrhea, nausea. You might have had that to start out with. Pacritinib, again, most common: nausea, anemia, peripheral edema. Again, peripheral edema is something that could be caused. You might have swelling because you have a blood clot related to an underlying condition. Make sure you know what you're going to blame on the disease and what you're going to blame on the drug. Here, if you look at polycythemia vera, again, low-risk disease here is going to be, you're going to be managing cardiovascular risks. You might use aspirin, phlebotomy. Other recommended treatments might include Ropeg or Ropeg interferon, which is now approved as Besremi. We'll talk about that. But again, symptomatic is right here in the middle. Symptomatic with potential indications for cytoreduction here means something a little bit different. We are often looking for disease-related blood clots or bleeding. But here we're also looking at splenomegaly or pruritus, night sweats, fatigue. So even here, even in patients with polycythemia who might have blood clots, who might have objective disease caused problems that would drive us to treat, we still have pruritus, night sweats, fatigue as part of this. And if you start out with fatigue, a lot of times drugs can actually make fatigue worse before they get better. So that's something to think about. High risk, you're looking, again, cardiovascular risk management. You're looking at aspirin, you're looking at phlebotomy in Vera. But here, again, you're going to see hydrea, you're going to see PEG interferon, and you're going to see Ropeg. I'm going to talk about some signs and symptoms there. But monitoring, if you work along with your physician through the algorithms of where am I on this guideline, and how are you thinking about which treatment to pick for me? What did I start out with? What am I ending up with? I think it makes it easier for patients to get a sense of whether the therapies are helping them or not, because this isn't the type of disease where we can just wipe out everything and say it's gone. Again, I wish it would be, but it's not like that. So we're going to have to be very clear at the beginning. What did I start out with? What is my treatment doing to me? And is my treatment making my symptoms better or worse? Is it making anything measurable about the disease better or worse? And I do think it's sometimes helpful to follow along this type of an algorithm to get to that answer. Now, if you look here at ET, once again, you are going to see I think I've made the points that I wanted to about following along in the therapy, following along in the algorithm, but the drugs that you're going to see pop up again, hydrea and interferon. So let's look at what those side effects could be. And again, this is something that is what pops up on the summary portion of the package insert. If you dig deeper, you find lists of lots of different side effects and symptoms that people had during the clinical trials of these agents. And I promise you will have had some of those, just because everybody has some of those. A respiratory infection, a cough, abdominal complaints. There are lots and lots of different ones that are associated with all medications. There's no free lunch in medicine, and all medications have side effects. If you look here at side effects of hydrea and anagrelide, which is used sometimes, although less commonly recently for ET, hydrea, hematological side effects most common. I would say that is the most common and most important thing for all of the drugs related to MPN management, is what's happening to your blood counts. But here, there's gastrointestinal symptoms and anorexia also listed, both of which can be associated also with the disease. If you look for anagrelide, headache, palpitations, diarrhea, edema, nausea, abdominal pain, dizziness, it looks like a long list here. This is what they have right at that front page of the package insert. But these types of symptoms and complaints are listed almost universally with drugs that can be administered for MPN. And if you look here at PEG interferon or Pegasus and ropeg interferon or Besremi, you're going to see here that the fever, fatigue, myalgias, headache, they say flu-like symptoms. Most common for ropeg, again, influenza-like illness, arthralgia, fatigue, pruritus. Well, pruritus, not so much. That's going to be part of the, that's not going to be part of flu-like illness, but pruritus is part of the disease. So how do I know whether that's the drug or the disease? You have to think about that. And then flu-like illness, well, I got to say, in 2022, what you don't want to hear is flu-like illness, because flu-like illness means somebody's going to be testing you for COVID every 15 seconds. So these are diseases with lots of symptoms. These are medications with lots of side effects. They're actually manageable side effects. Every single thing that I have shown you, I use every single day on patients. I have patients who are taking all of these medications successfully and managing these as tolerable side effects. But I think that when you initially have the disease and when you're working through it and when you're trying to realize all of these different things that can be caused by both the disease and the stuff that we use to treat it, I hope it's helpful to kind of think about it as, what is the disease doing to me? What is the drug doing for me? And what is the drug doing to me? I will end by saying that these recently published data underscore something which I think a lot of women certainly feel, because so many side effects are nonspecific and are things like headache or fatigue. Historically and currently, women are accused at least of complaining of more side effects. And actually, if you look at these data, which were just published in JCO, so this is not, from Time Magazine, this is from the Journal of Clinical Oncology, looking at symptomatic in blue, objective hematologic and objective non-hematologic severe adverse events. This is for patients getting chemotherapy, immunotherapy, targeted therapies, and then any therapy in cancer clinical trials. And women have a lot more symptomatic as well as objective, both hematologic and non-hematologic adverse events. And there are lots of reasons for this, ranging from, should the doses of medications be the same for men and women? Are women more likely to report symptoms? Are women more likely to over-report symptoms? Are women continuing to be underrepresented in many clinical trials, which historically has been the case that men were more represented? So I do want to end by saying that we do have to be sensitive to the fact that women may be genuinely experiencing things in a more symptomatic manner on therapy. Women may be reporting more because we're more communicative and talkative historically, and that is possibly part of this. But I think everybody has to pay very close attention to symptom management, medication side effect management, and listening to patients in this collection of diseases where symptoms are so pronounced, so varied, and so affecting our patients' lives. And I will stop and turn it back to Anne.
Thank you so much.
This is my fabulous team, by the way.
Thank you. Can you hear me?
I can.
Oh, great. That was fantastic. Thank you so much. To be able to say this is going to happen or this could happen. Like you said, every drug I've ever picked up has a litany of issues that could, be derived from the use of that drug. So this was really good. Thank you so very much, Gail.
I like to say that nobody would take a Tylenol either if you read the package.
No kidding.
So it's very worth it. It's very worth it. to kind of sit down, take a deep breath, and then start circling things. Wait a minute, did I have this before I even took the drug, before you start blaming the drug?
Right, right. My daughter was great at pointing things out to me from everything we had in the house. But thank you so much. And I hope to see you soon. I know you're really busy.